You ready? Is everybody ready?
Yeah, ready.
Perfect. Well, this is a heck of a turnout here, so obviously there are people very interested in Julie's topic. My name is Kevin Shea. I am with the company called Galen, and what we do is provide transition services for health systems providers that are looking to transition to a new EHR or archive old systems. Core to what we do happens to fit really well with this particular topic is it's all about data and having access to data and doing something with that data that's of value. And so with that, what I'd like to do is introduce Julie. Julie is with Banner. She had mentioned to me that she moved from the East Coast to come over to this beautiful spot right before COVID. So she's had a little interesting challenge there, but she's done a lot of really good work with Banner. And I believe they're getting ready to implement some of the things that she's been doing. So with that, I will turn it over to you.
Thank you. Good morning, everybody. My name is Julie Smith, and I am with Banner Health. So I'm the Vice President of Enterprise Data Management. So I have the great responsibility of moving the data around Banner in all of our facilities. We do operate in 6 states, have 30 kind of hospital locations and 800 clinics. So lots of data coming in and out of Banner every day. And so my topic today is back to basics. And let me see if I can know how to work this thing here. So one of the things that after kind of 2 years of COVID that we've discovered is we now have our data on a platform. So we have chosen the Innovaccer platform for our population health data as well as our delivery data lake. And so during COVID, we had to very quickly amass a number of different source systems onto our data warehouse with Innovaccer. And so our goal in that was trying to build a unified data model across Banner. So we went from various source systems, Excel spreadsheets, CSV files, to real source systems like our HIEs in every state and our billing and EMR systems. Banner has our Cerner system, as well as we have an integrated sense. So Banner is both a health plan and a provider organization, and we also have a research organization. So with that comes a lot of different types of data. So we have, after 18 months of moving really quickly and putting a lot of data on the platform for reporting and analytics for COVID and daily operations at Banner, what we're seeing is we have over 70 systems at Banner that have demographic as well as provider data in them. And when we started merging those source system data that had that provider information in it, and all of us know that having the providers right drives all of our attribution, our membership, our patients, our billing, the word provider is your main driver, is what we've learned, in the last 18 months, to make sure that all of our data and our claims and our patients and our membership are getting the appropriate care. That word provider kept coming up over and over again. So we partnered with a company called ClearSense, and we have gone back to what we're saying are the basics. What are all of our systems that provide us data for provider, member, patient, and NPI and EMPI? So we started back, kind of at the beginning. So that's what I'm going to talk about a little bit today. A little slow. Okay, there we go. So as part of what we've done is we realized very quickly that we have over 30 lines of business at Banner that bring us data every day. Each one of those lines of business looked at the provider, member, and patient data very differently, as well as had a different I will say, definition of that data, as well as the source systems of that data. And so what we did is we gathered, obviously, our 100 different data sources across the enterprise that had provider data in them. And then 19 of those data sources, were kind of removed. But in our stage 2 development, 78 of those data sources were actually prioritized. So imagine having 78 different data sources that have, your basic 10 data elements for everything you do every day. So we selected 20 data sources. So I'm sure, our EMR systems, our billing systems, our finance systems, as well as our provider manager system, our scheduling system. So, when you look at the expanse of that data, we realized very quickly that we had to concentrate on our main systems and then consolidation of those main systems so that we had the right data elements. And funny enough, I think one of the things we realized is our HR systems and our finance systems contained data that we were using for billing and other things that didn't match just the basic data that we had in our credentialing systems and our HR systems. So we've gone back and said, okay, so wait a minute, from the top level, what is our data hub and what elements would our data hub contain that would represent all lines of business at Banner? And so we started down that kind of road of what should the data hub contain, what domains should that data hub contain, and who are our key stakeholders in helping us define the definitions for those 50 domains of data at Banner. Yeah. So I think all of you, if you look at these, you're probably smiling at yourself. So I think one of the things we realized is just because I say provider or member or patient, we all, depending on where we work in Banner, we all have a different definition of what that means. So the one thing we've done is we've put a governance committee together. We have representation on that committee for 23 different lines of business in Banner. And so we use a product called Calibra, and that's become our data governance tool. And we meet monthly to say, we've pulled all the system data in, and then we review each month a set of that data to say, is everybody comfortable with the definitions of this data? And in your daily life, is this how this data would be represented, or do you have a different definition of data? And so we've learned a lot from involving all of our business stakeholders, because the way finance looks at a piece of data, patient data, isn't the same way that a physician's going to look at patient data, isn't the same way that the insurance division is going to look at that patient data, which is to them a member, right? So, and then also duplication of data entry and storage. So we have made it a point to pick a vendor where we could unify our overall data models. And so we have a vendor that, as we bring data into our lake, that vendor separates and consolidates and standardizes and normalizes that data into a unified data model. So when we look at that data in kind of a stage 2 area, we can see all of the different data elements across Banner that have, provider in them and where they're located, and they're bucketized based on the definition of that data. So that was a super important thing that we did. And then our provider data quality issue. Back to basics meant we had a provider system, we had a credentialing system, and then we had an insurance division system where we were all giving definitions of provider and location and specialty and primary billing location. And so we realized very quickly that if we put the 3 systems side by side, depending upon who at Banner entered that data, it was a different definition of that data. We would have a cardiologist coming out of credentialing, and then on the same side coming out of the university hospitals, we would have interventional radiologists, cardiothoracic surgeon. So we've really looked at those data elements, and we've started to document the systems and the people and the places where that data is coming in, and standardize on, hey, what should the definition be? You know, we think credentialing really should be that physician's, you know, main focus, and that should be the start. And then it's okay to put additional, you know, definitions of what he does at each of those locations. But does that make sense if I'm going to send this information to the insurance division, if I'm going to send this information to access at the state? So there's a lot of different things that I don't think, you know, we were like actually thinking about when we started this. And then the manual processes. So we've looked at all of the folks at Banner that are entering information manually, and from our insurance division, from our call centers, from our credentialing, from our registration clerks, and said, what is that? What are those 10, you know, data elements that we must have every time? And we're slowly but surely rolling out those top 10 data elements. And there's a drop down now that says, hey, these are the only things that you can pick from. And then we're looking at how we can make sure that quality control goes all the way through Banner. And then the other thing we've done is the silos. We've looked at the silos of data, and we've tried our very best to say, hey, you know, you have a data source that's very important to us. How do we get you to bring your data in, and how can we source that data and make it electronic so that we're receiving that data, and we're cleansing that data, and we're normalizing that data, so we're not sharing that with downstream systems. And what's funny is when we're looking at this, what we realized is we have kind of a main system at Banner that's providing downstream data to 15 or 20 systems that might or might not have had the correct data for the system that was receiving that data. So that's the other thing that we've done, is we've taken a look and said, what is the system that's receiving that data? What data elements should they get, and what should they not get? We were basically overriding all the way down every single day, right? And so it made the systems over time that the data was just not correct, right? Because I have, you know, blue here, and if I'm sending it to green, green's going to be like, I don't know what blue is. I'm just going to skip it. So that's what we've learned. And then we've also, I think, the most important thing that we've done at Banner is we've named data stewards for each of our lines of business to say, you're the data steward. If we have questions about a data or a piece of data element, or you have a new system coming in, please come to us, you know, give us the basic data elements of that system, and let's walk through, and let's normalize that data the way Banner wants to see that data throughout the organization. So yeah, so this is kind of, I think most people are going through this kind of from a day-to-day basis. So you know, first of all, we put our people in place. We picked a technology, we picked a main technology, and then we've looked at all the systems that generate data every day and determined where we've had overlap in those systems. And then our processes. We started very basic, you know, what are the definitions? What are our main data elements? And what can we do if a system is delivering us data from an Excel spreadsheet, or, you know, people keying in data? How can we automate those processes so that we're receiving consistent, standardized data across the board? And the other thing is multiple records for the same provider. So like I said before, we looked at our credentialing system, we looked at our provider manager system, we looked at our main EMR systems, and we looked at the data that we were sending outbound, you know, out into our internet to say, you know, where is that provider located? Have we updated the address of that provider? Do we have the right phone number for that provider? You know, that data, if you don't really stay on top of it, gets stagnant over time. And so we've made it one of our main goals to make sure that people follow that data throughout the processes at Banner, and make sure that data is updated and consistent all the way out to what we're calling the street, right? Where our members and our patients are accessing that data on the internet every day. Sorry about that. And then thirdly, manual data entry. So like most places, Banner has done some mergers and acquisitions. And so we've had lots of manual entry over time for that data. And we have lots of people participating, and working very hard to put that data in the system. But is it the right data? And do we have the right validation and quality checks in between? We were allowing that data to go into the system every day and be entered into those systems. And we weren't, taking our time to say, hey, that data can't go in until it's validated. We can't go in until somebody's checking that data. And so we've made it a point, going forward to have that QA engine kind of in the middle of that before it hits our main systems within Banner. And so some of the things is ensure our reference data and availability of that data is going through our data governance programs within Banner and our steering committee, and that decisions are being made on that data. And then we've also standardized on our abbreviations, and then we're publishing that data out of our data hub so that the downstream systems, receive consistent data and consistent data quality. Yeah. Yeah, of course. Okay.
You have the integration team.
Yes, we do.
And is this integration within our health, or are you when you do model and applications plus all the vendors, service provider, third parties, providing information? How do you influence to basically gather this type of
right? Yeah, absolutely.
So I just want to know what exactly.
Yeah, absolutely. And that's a great question. So one of the things we did is we standardized on, first of all, a platform where we would have a unified data model, and that platform could take all of our source systems in, and we have an engine. So we use the Innovation product, and that engine takes all of our data sources and standardizes them. And then, like you're saying, we have that quality control piece. That data sits in a what we call an L1 or L0 container until that data is validated, and we validate what the data is. Is it coming in the right format? Is it coming in the right standard? And then what systems is it going to? And then we bucketize that data going forward based on validation of that data into what systems. And we do use a third-party vendor as a middleman that's not part of Banner, that's actually validating that data. They're looking at it, from not a Banner scope, but from an independent aggregator scope to say this data makes sense. It follows the standards and guidelines. It meets the gates and criteria for all of the standards that have been established, and it can move on into the process. So we have over 500 source systems that we'll be putting on the platform over time. It's taken us about 18 months to put in. We have 57 systems on the platform now. We do take in, like I said, a lot of outside data sources, including our Health Current, our HIE here in Arizona. And also we have systems in Colorado. So Health Current has purchased the CoRio system. So we're integrating slowly but surely those systems. So we're moving at a pace we feel comfortable with to make sure that we don't recreate the EDW of the past, right? So I think that's a very good question. And we're also having a third party look at that data versus just the Banner from the Banner lens. Does that answer your question?
It does. And I have a follow-up with a two-part question. So I'm assuming that all of the companies are bringing it and people are reconciling for the process.
Yeah.
I'm assuming that you are using some kind of information.
Yes,
rather than cost.
yes,
Right?
absolutely.
That is what's going to go.
That's right.
Unless, the cost is as bias.
Absolutely. Yeah, absolutely. So we use the Innovator engine, which processes that data. And then we use Calibra, which is a data governance tool. And Calibra allows you, interestingly enough, you can attach to a backend system and you can actually suck the data in. And if Calibra doesn't find a place for that data to reside, it calls it out and says, this piece of data or this discrete data element is not in Calibra. We don't have a definition for it. It doesn't fit into our catalog. What is it? Do you need it? Where do you put it? So I love your question, because I think when we went into this process, we're like, oh, this will be easy. And there's a lot of data, but a lot of it's the same. And what we realized over time is there's a lot of data and a lot of it may be the same word, but the definition of it is very different. I mean, I think my favorite story is, for us, during COVID, we had to do a lot of reporting to HHS and to the state. And so for us, head in a bed should be easy, right? But do you know how many systems we have at Banner that captures head in a bed? And then if I'm capacity management or I'm transfer or I'm a nurse on a floor, head in a bed means totally, something totally different. And if I'm in the emergency room and I'm going to put somebody inpatient, what does that mean? And so that journey, has been, I've been in this industry a very long time, but that journey for me was, I can tell you, after 35 years, eye-opening. And I think dealing with the COVID data and having to report that data outside of Banner made us go, wait a minute, we don't have a standard definition for what this means. And what is the state asking for? And what is HHS asking for? And what is Banner going to send them? And so I think that was a super, lights on. We really need to take a step back and look at what this data looks like. So the journey's been, from that perspective, I think it's helped us, like I say, step back and take a look at our data and how clean or normalized is it, and can we use it every day? If somebody comes and asks us what head in a bed means today, we actually have a definition of that, and we can tell you the 9 systems that provide that data within Banner, what head in a bed means in each of those systems. So depending on what you want, you can now pick your category and take that definition and use it. So that's a common data element now. So yeah, I love your questions. Thank you. Very quickly, we've automated as many systems as we could. We've worked with vendors to come in. I know, you're a vendor that's sitting on the outside that says, hey, I can help with data management. We've worked with vendors to take disparate data systems, and where we could automate those and or put them in a system where that data could be addressed and automated. For instance, we had to walk around our hospitals every day and count the number of vents we had in each of the rooms. At first we were like, oh, we could do this as an Excel spreadsheet. But then when we started realizing that the vents and the availability of those vents across our 6 states was like a major question every morning on our EOC calls, we very quickly got a vendor in and took all of our inventory and put it in an automated system so we could take our daily vent count, as well as we knew what we needed to order. We knew what we needed to supply. And we also knew where we could share vents across the Banner system. So I think some of those things, really pushed us to automate some of our kind of systems that we had kind of manually done for many, many years, and had a huge biomedical team that, did that for their jobs every day. So just kudos to the biomedical team at Banner. They've done things beyond expectations, and I'm very grateful for all the work that they've done to help us, put all that inventory into an automated system. So this is kind of, I would say, kind of our kind of our strategy moving forward. You know, we're working on, you know, constantly working on our automated integration. We're constantly working on data validation and reference data. And then we're kind of at this step of our master data management. So our goal now is to take all of our different disparate data systems. We believe we have them all, and start really, you know, kind of focusing on our master data management or our data hub, you know, that has all of those systems in it. And then look at our duplicative systems to say, we have 5 systems that provide us this set of data. Which system has the best capabilities, you know, 1 year, 2 years, 3 years moving forward? And, you know, we're consolidating those systems, and that consolidation is allowing us to put both, you know, capital back in our budgets and make us, I think, make better decisions about the purchases that we make. And something that looks shiny, does it really fit the banner mold of strategic, standardized? How do we, does it really, what about that system helps us meet our standards of patient care and member care? And does it drive, overall financial and strategic direction of Banner? So I think we've really started to look at those systems and say, we already have that system. That's a great system. We're not ready for that. That system looks like it has potential. It'll take us 2 years to get there. So we've started having those strategic conversations. And then, I know that everybody likes to say they have AI and metadata and, data profiling. I would say, we're probably 18 months to 2 years out in that journey, but it's a journey we're, I think, dedicated to, as well as actively monitoring the capabilities that are out in the enterprise. And the other thing we've done is we've taken our old data centers and we now have moved our data centers to the cloud. So we have an AWS instance, we have an Azure instance, and then we also have a private cloud for our research instance. So we're looking at, the bleeding edge technologies out there, and we're also going to use Snowflake. So we're trying to get tools and cloud technology to move Banner forward in their data journey.
I have a question. Do you see a benefit in having those multiple vendors on the solution? Doing that research to see if we can do better with them.
Yeah, so that's a great question. So we did a study on how many, what's our main systems we have at Banner today? Do we have Azure? Do we have this? So what's interesting is we have a lot of Microsoft technology, but our clinical vendors are moving to AWS. And so Cerner and Epic and, a bunch of the stuff that we're doing in population health, those vendors were using the AWS cloud. So it helped us look strategically. And so our delivery side of the house, Azure, Azure, Snowflake, most of our applications, we don't have, it's not a big lift for us. And then on our population health side of the house, our insurance division side of the house, all of those clinical vendors, from an aggregation standpoint and a data standpoint, being able to interact in the cloud with those clinical vendors, because Cerner, our main EMR, is sitting on AWS, right? And their Millennium Standard, their Healthy Intent Standard is AWS, and their Millennium Standard will also be AWS. So moving that data cloud to cloud really saves, some of that thought process going forward. So yes, we did that kind of study. Yeah.
I mean, one of the big issues always around master data management is when an update comes in, gets that update, or how do you manage that? And it sounds like you're just getting into the
We are, yeah.
Can you talk a little bit more about how you foresee that going? So, for example, if a patient comes into a clinic and they have new information, is that going to get there? How is it going to get dispersed throughout the enterprise? Or is there a review process in the hub that takes care of that and that updates master data?
Yeah, that's a great question. So in fact, we had a planning session yesterday. And so we've identified 10 systems, right? Going forward, that kind of would be our master systems, right? So we have our EMR, we have Salesforce, we have Workday, we have our claims systems, and then we have our lakes. And so that hub, as we start to build out that data hub, we want that data hub to say, I'm going to get that piece of data, and I'm going to, look at that piece of data, and I'm going to decide what downstream systems would receive that data. So we're just embarking on that journey right now. So, we're very excited about it. We're about 5 months in. We did the assessment piece first. We gathered all of our data, and now we're embarking on that journey. Where should it go? Does it need to go to the hub, or can it just go to the source system? And depending on what those data elements are, does it get kicked up to the hub, or can it stay in that source system and be pushed down? So that's a great question. Those are decisions that we're just now making. We met with our main vendors yesterday, and then we're having bi-weekly meetings moving forward with those main vendors to say, and we want to, I think the main thing is we want our vendors to be in the same room. We want to hear, we're going to use your system for this, we're going to use your system for that. Let's agree on what we're going to use your systems for, and that you're going to be responsible for that piece of data and making sure that that data is right, and then generating that data downstream. And I think the journey to get our vendors to work together and sit in the same room and share ideas, I think has been probably the most interesting and best thing that we've done, because all of our vendors want to be everything to us for everything. And we're like, hold on, we can't do that, because you can't be everything. And if you don't have that as your core technology today, we don't want you to build it. We want you to bring your core technology and what you do best to Banner, so that Banner systems are the best in class. So so that's a great question, and we're just embarking on that journey. So it's new information every day. Anything else? Sorry. Oh.
Bring those people, the stakeholders together, that process to decide on those definitions, or my experience about family. It's very regular chat.
Yeah. So what was funny is we did it individually first, because we wanted everybody to feel comfortable to share their data, right? And then we brought everybody into the room, the data stewards, and we said, okay, there are 100 different source systems. You've given each of your definitions. What do you think the definition should be? And what's interesting is, I think that's the first time that people started sharing together what their definition was, and understanding how important that global definition of that piece of data and how it was understood was so important, because outside of their blinders, there were a bunch of other people that were using that piece of data throughout the organization. So I think we did it independently, and then bringing everybody together kind of drove that collaboration. And now everybody comes to the meetings and everybody has information. So yeah, it worked for us. So I think that's kind of a good way to do it inside your organization.
Any other questions?